lots of different ideas of how to best reform our healthcare system, but as you might expect, it is quite difficult. Today we're talking with Dr. Gus Geraci, who is a consultant who specializes in physician coaching, physician engagement, conflict resolution, and more. There have been times in his career when he has tried to reform the system to make it better for doctors, and he's going to tell us just how hard it is. This is the FLATLINING Podcast from Fulcrum Strategies. Joining me right now is Dr. Gus Geraci. He has more than 40 years of clinical, administrative, and teaching experience in the healthcare industry. As a consultant, he helps physicians lead and shape healthcare delivery to provide quality and value to patients and the community. He's practiced emergency, occupational, and family medicine, including inpatient care. And he has many years of medical management experience while serving in roles as diverse as a solo family physician in a fully computerized office to a medical director in commercial and Medicaid health plans. He was also the chief medical officer of a Fortune 15 healthcare vendor. His special interests include IT and medicine, physician management and profiling, and quality improvement. And he operates two websites, which both will be linked in the show notes. One is drgeraci.com, where you can learn more about his consulting business, and rateyourhealthcareemployer.org, where physicians, nurse practitioners, and physician associates can anonymously review their employers, past or present, to help colleagues find better jobs and avoid bad employers. Dr. Gus, it is very good to make your acquaintance, sir.
Thank you for having me.
Also with us is our president and CEO, Ron Howrigon. Ron, hello.
Hey, how are you?
Dr. Geraci, we like to talk a little bit about background with the physicians that we interview on the program. We like to learn about what got you interested in medicine, because it seems that every physician we've talked to has had a different path as to how they decided that was the career, the direction that they wanted to go in. So if you don't mind, tell me a little bit about what got you interested in medicine and what got you interested in the different specialties that you've worked in.
Sure. So a classic nerd kid with the glasses and the pocket protector and the slide rule in the pocket, started out with an interest in science. I was always a science nerd. And I realized along the way that I enjoyed doing two things. One was talking to people and the other was helping them. So when I went to when I went to college, I got my degree in psychology, and I thought, I'm going to be a talk therapist. I'm going to be the guy that people come and talk to when they have problems. Going to college, I realized that there were several things happening at that time in the 70s, and one of them was that drugs for psychosis were suddenly exploding, and I realized that talk therapy may go away to treat patients with illnesses like schizophrenia, mental illness, depression, anxiety, was going to be in the next 40 or 50 years through the route of drugs. So I actually applied to medical school thinking that I wanted to be a psychiatrist because you could both do talk therapy and also prescribe one of the many new drugs that were just exploding onto the market to help people with those issues. Of course, that was the politically incorrect thing to do back in that day because primary care was all the rage. But I managed somehow to get into medical school, and once I started medical school, I realized that two things. One is that a lot of psychiatrists weren't doing as much talk therapy as much as just prescribing, and the other thing was that I enjoyed all of medicine. I enjoyed seeing kids, I enjoyed seeing adults, I enjoyed seeing women, I enjoyed seeing old people, and I enjoyed seeing everyone of every size, age, etc. And I didn't want to be limited. So that led me to family practice. So I ended up doing my residency in family medicine, practicing family medicine, emergency medicine, teaching family medicine, and ended up into administration because I realized that as a family physician, I had a panel of maybe 1,000 to 2,000 patients that I could help. But in administration, my panel would consist of hundreds of thousands, if not millions of folks that I could help improve their care. And so that led me down the path to becoming a administrator for the dark side, as many clinicians are fond of calling it. And I actually retired 4 years ago and resumed doing some consulting work, and that's what I'm doing today.
So let me ask you this, because we've talked to some physicians before that have gotten out of the clinical thing, and for them, a lot of it was burnout. They felt that they just couldn't keep up with or provide the quality of care that they wanted to provide. But for you, it sounds like it was more of mission. Is that a fair assessment?
Well, I will tell you, the mission provided the boost, and the burnout provided the breaks, if you will, on a clinical job, because I did enjoy all of my clinical work. And in fact, my last clinical role was as a family physician in the middle of my career in my own practice in a suburb of Harrisburg, Pennsylvania. Unfortunately, I did it at the perfect exact wrong time. I developed this great business plan and for growth and expenses, and my 5-year plan projected 3 to 5 year increases in expenses and a growth that would bring me at the end of 5 years to being able to not only support myself and the practice, but bring on partners. And the reality was that in the first year after I opened my practice, malpractice went up 20%. Wages outraced my estimates, and income went down. The average payment relative to inflation actually decreased. So we struggled along for a few years. I actually grew the practice to 3 physicians and a nurse practitioner. And we realized we needed one more doc to break even and actually start to make money. And the 3 docs in the practice could stop moonlighting to support themselves and actually just do the practice full time. Our young doc signed a contract with us. She was coming out of residency and signed the contract with us. She was supposed to start on a date certain. 2 weeks before she was to start, she gave us notice and said she had accepted an offer from a competing health system who was employing docs. And by the way, I had previously hired physicians and worked as the chief medical director for that health system. And I used to do the thing that someone else did. And she was hired away from us for an increase in salary of $2,500 a year. And we put our heads together, the 3 docs, and we realized that unless we could break even and it was going to be impossible to recruit a new doc, we closed the practice. And we all just went our separate ways. One of the docs opened her own practice optimistically, thinking she could do better. The other doc did full-time what she was doing, moonlighting. And myself, I went full-time into administration. And that was the end of that practice. So it was partially burnout because I was tired of working 7 days a week with call and not making, as my partner used to say, as much as a good plumber.
Well, so I've
ahead,
got to ask, what suburb of Harrisburg?
Camp Hill.
Okay. The reason why I ask is my last job with a payer was Capital Blue Cross. I lived in Mechanicsburg.
Mm-hmm, mm-hmm,
so,
yeah.
And very familiar with the malpractice issue there, especially in the center part of the state, because you guys got hit with rates that were really driven by either Pittsburgh or Philly.
That's correct.
And that center chunk of the state, it was horrible. I know when I was there, the obstetricians were just getting crushed on malpractice. It wasn't theirs, really. It was Philly and Pittsburgh, but it had to be rated across the state. So,
to the best of my knowledge, at this point in time, there are zero independent OBGYNs in Philadelphia.
Yep.
The only OBGYN care is provided by the large health systems.
Yep.
And every single one of the independent OBGYNs in Philadelphia has left.
Yeah. So how many years ago was that you closed the practice?
A little over 20 years ago now.
See, now this is the It's a Small World segment. It was 20 years ago this June that I left Capital Blue Cross. I was there for just a little over a year, but it was 20 years ago this June that I left. Well, I was VP of networks there. So
I probably know the medical directors you worked with.
I'm imagining you do. Yep. It is a small world. There's only actually a few of us that do this, and we just rotate around and do different jobs. So that's interesting.
For interest, I opened the first practice in South Central Pennsylvania with electronic medical records. I was the first.
Wow. I'm sorry, Matthew. I just
no, that's okay.
When you said suburb of Harrisburg, I was like, I bet I know where that is.
Let me ask you this, Dr. Gus, and then I want to turn it over to Ron to talk about kind of the meaty part of our discussion today. We've had conversations with physicians and public health advocates about the impending physician shortage that we think we're getting ready to face here in this country based off of graduation rates from medical school and such. Do you worry that the experience you had in trying to run your own practice, do you worry that that's going to accelerate a physician shortage in this country?
I don't worry about it. I think it's happening.
Okay.
The reality is that I think the latest statistic I saw was that it was somewhere near 80% of physicians in the country are now employed and not independent. When I was graduated from my residency in '83, that would have been more like were employed and 80% were independent. In fact, the idea that you would go and work for a hospital or a health system wasn't even on the radar. You graduated residency and you opened your own practice. There are states that kind of held out longer. Texas, I think, probably is below 80% still. But I know when I left clinical practice in Pennsylvania, it was at about 60% employed. I think, your original question, am I worried about it? I'm not worried about it because it's happening. Mm-hmm. And I think it's going to get worse. And I think that physicians more and more are going to either do concierge care or one of those models where instead of taking care of 1,000 or 2,000 or 3,000 patients, they're going to take care of 500. Mm-hmm. So not only are the numbers going down because physicians like myself have left practice, but they're also going to take care of fewer patients. And I will add to that the fact that this generation, and I hate generalizations, but I think it's somewhat appropriate. This generation of physicians don't work as hard. They value life-work balance. Mm-hmm. And the days I was just talking to my wife earlier today, I said, as I was raising my family, I realized I often neglected them because I was busy with my practice. The docs today do not want to do that. And so the idea that you would take care of 2,000 patients is gone. Mm-hmm. When I was a resident, it was not unusual for a physician to see 40 or 50 patients in a day. Now I read on some of the strings and on the internet, people feel overworked seeing 20.
Yeah.
And that was pretty much that you couldn't see 20 patients a day, you couldn't survive financially.
Yeah, 20 was a slow morning for you.
That's right.
I mean, exactly that was an easy morning, not a full.
Right.
Well, Dr. Gus, we want to thank you again for coming on the program today. I know Ron and you, I believe, have had some discussions online about a couple of things that have been kind of hot button issues lately. And so I'm going to turn it over to Ron to talk a little bit more about that.
Sure.
Yeah, and I guess preface this a little bit. This is the first time we've sort of met other than online, but over the past probably couple of months, I developed an incredible amount of respect for you for a couple of reasons. One, and recently I know I saw some exchange you had with somebody where the individual got personal quickly, and you didn't lower yourself to that, which is so easy to do when someone is sitting behind a keyboard, and you maintain professionalism that way. If that's, I can't have a discussion if we're going to get personal. So that I have a huge amount of respect for, but also that, and this doesn't happen much online, that all of your comments were always not only well thought out, reasoned, and logical, but it also struck me that you were also listening. And it was, well, I have the answer to everything in the world, and just, trust me. It was, an actual exchange of ideas at an honest level. And that's so rare that's one of the reasons why I said, geez, we gotta get this guy online on the podcast to talk about specifically. I want to whole push-pull between denials, prior auth from the carriers, and how the physicians feel about it, how the carriers feel about it. And I guess I would start with, and please, and I know you will, correct me if I'm wrong here, where I think you and I have really solid common ground. And that is that I think we both want patients to get the right care at the right time in the right setting, that there's no, that it was, well, I just want healthcare costs to go down and I don't care if that impacts. No, it was, they should get the right care. Okay. I think we also both agree that there are plenty of examples of physicians, things that have either questionable or no clinical value, things that maybe were done for monetary reasons only. In any profession, there are bad apples. And I know when I was with Cigna, this is my favorite story of overutilization. We had a neurologist who happened to own his own MRI machine, oddly enough, who, and I can't make this stuff up, who was ordering an MRI of the brain on the same patient, an average of every 9 days for a year. And his justification was, well, I'm watching something. Now, I'm not a doctor, and you can tell me I don't think there's any clinical rationale for doing that. It was, I think, purely a financial one, and that's about the worst that I've seen. But I think we can come up with a lot of examples where doctors aren't doing the right thing. I think we could also both come up with a lot of examples where payers right now are doing the wrong thing. Whether it's a computerized denial or some of the things we've seen in recent articles where it looks like, physicians are being pressed to do things very quickly rather than considering the patient. So, correct me, but I think both you and I would admit there's offenses on both sides of that fence. There's bad actors on both sides of the fence and good actors on both sides of that fence. And so what I really wanted to, if you will, focus on is, okay, well, given that it's unreasonable to think we go back to the days of, hey, if the doctor ordered it, it should automatically be done without question because we don't have unlimited resources. And that it probably shouldn't be that, the payer gets to just deny everything and sort it out after the fact. So what do we do? I'm really interested in your ideas, solutions of how do we get to that sweet spot where we're not providing unnecessary care or monetary care or care without clinical value, but we're also not denying things inappropriately or overburdening physicians with stuff that also doesn't have value. Is that a fair, and again, correct me if I'm wrong on any of that, fair setup?
Absolutely. Firstly, Ron, let me thank you for what you said about me. I appreciate that. I think today there is too much hate.
Yes.
And too much not listening to the other side, and too much putting people at polar opposites and not seeking or even trying to find middle ground. And I'm sure we could share lots of anecdotes about, ending up being called names, as you saw happened to me.
Yeah.
But the gentleman, the physician that did that to me has a point. And in fact, his point is that there is a solution, and he's got part of the solution. It's just with his viewpoint, he sees only half. And so, believe it or not, I have given this a lot of thought. Mm. And in fact, I have actually tried to solve this problem in the past. I was the chief medical officer for the Pennsylvania Medical Society, and my title was in value or something like that. And that's what we tried to do. We tried to figure out, prior to my time with the society, they had tackled this problem. And the urology, a group of, I won't get specific, and I sort of did, but a group of specialists in South Central Pennsylvania said, we've got to get together and create criteria for our procedures, because the insurance companies are all over the map. Mm-hmm. They, we get denied by some and approved by some, and, we've got to get together and fix this. So the society said, okay, let's get a bunch of you together and let's create a South Central Pennsylvania standard of care for your specialty. They couldn't. They could not agree as a group of specialists practicing the same specialty as to what they were going to find acceptable for them. And so that effort went by the side. The other effort that was tried was the idea of if we have create a committee that will review physicians who have concerns that are brought to us. So instead of complaining to the state medical board, you now complain to the medical society, and that went not well, because there but for the grace of God go I, and we don't know what was happening, we don't know the whole clinical picture, we don't know this, we don't know that, and so an effort to try to do that. But you asked me, and secondly, I'm going to say I'm going to try and capture your video and post that on my website. But thank you for the praise.
You're welcome.
The answer actually is not easy, and we've talked about this online. We've chatted back and forth. The answer is not easy. There are bad actors on both sides, as you've pointed out, and both need action. The question is, what action is that? What I have thought of is that we should have a national peer review committee. Something, created by some body, and I don't know who that body should be. I always hate involving government, but someone needs to form a national peer review committee that is comprised of academic and practicing and local physicians in all the specialties. And they need to be charged with reviewing the behavior of physicians. Now, how do we get to that? Well, the physician that you saw me get insulted by actually has a good idea, and that is to code mistakes, to start coding mistakes. So one, he believes strongly that there should be a code for the amount of time spent processing and doing prior auth peer review appeals. I agree with that. I think that's an appropriate thing. I think it should be a time code. So, XYZ 01 is 10 minutes, XYZ 02 is 20, et cetera, et cetera. But I also believe there should be a code that the insurer then uses for every time that they have a denial for a physician that gets appealed or doesn't get appealed and is allowed to stand. So that if Dr. Gus Geraci in Camp Hill, Pennsylvania, has 100 denials a month from Capital, another 100 from the other insurance. Why isn't that happening today? One, there's no code for that.
Right.
Two, the number of cases does not achieve statistical significance for any one insurer, and they don't share data. So you have, when I was in practice in Camp Hill, I had about 50 different insurance companies that I participated with. Out of those, maybe 10 or 20 of them were managed care. But so me, with my panel of 2,000 patients, if I got one denial every 6 months, that was a lot. Statistically, there's no value to analyzing one every 6 months.
Right.
But if you if you aggregate all of the data from all of the insurance companies, requested, denied, that's it, just requested and denied, and then report that to some third party and allow them to analyze the data and see if there's a pattern. Now, with the AI and computer processing and all of those things, I think that's doable now. That if we were to create a code for denial that stood and fed that into a database, much like we do malpractice episodes, fed that into a database and allowed some third party to analyze that database and look for anomalies. I can understand a doc getting denied once in a while, but if a doc gets denied pretty consistently on the same thing over and over and over again, that's a flag that that person is doing that to non-managed care patients on a regular basis and getting away with it.
So,
and go ahead.
I love the sort of the thought process. should there also be the sort of the mirror image of that, of a code measuring the payers who deny and get those overturned?
Absolutely.
Okay.
Absolutely. And that's the flip code.
Right.
The flip code is the amount of time spent on appeals, denials, peer-to-peers, et cetera. And just like insurers profile docs for how many types of visits they do, short, medium, extended, this similar third party needs to analyze, why does XYZ insurance company have so many appeals that are overturned?
Right.
There's something wrong there. And why is their denial rate in South Central Pennsylvania 25% instead of 10%, which is what all the other companies do?
Right.
I think, I'm always leery to mention a name because I'm one guy and I don't want to get sued. But there are clearly insurance companies that are doing bad things.
Sure.
And you mentioned the doc that was in a lawsuit and said, they give me 2 minutes to review a case.
Right.
That insurer needs to be looked at by somebody.
Well, and what I like about, and I'm the same with you, that I'm hesitant to have the government be the solution to things because they are often not very good at being solutions, but that may be the right place for it. There are definitely things that have to go there, but what I like about that is it's a two-way street, and I agree with you. Like the doctor I described, the neurologist who was ordering, an MRI every 9 days, in my opinion, that guy shouldn't be practicing medicine. That's wrong. Now, I get it that MRIs are not, they don't create radiation like CTs would, but that's still wrong. You're wasting resources. Okay. But the flip side of that is there needs to be some way to hold payers accountable for when they're, because as much as, and I used to say it when I was on the payer side, I would say, oh, we're not denying care, we're only denying payment. Well, you and I both know that in a lot of cases, the denial of payment denies the care because the patient can't get that without the payment. And so there needs to be, I think, a similar sort of accountability, and then something that could or should happen to that carrier. Now, the good news is everyone can fine carriers for bad acting. And so you could have a scenario where they say, well, if you're found to be guilty of inappropriately denying beyond a reasonable amount, they're not going to get it right 100% of the time. Here's a fine, here's some penalty that will make it stick. I love that idea. As you were talking about, the interesting thing is, and I've written a couple of books about healthcare reform, and one of my concerns, and this must be frustrating for doctors, is why is it that I can take two patients, and the first patient, and they both have the same exact presentation, and the first patient I order X and it's approved, and the second patient that has a different carrier, they go, oh no, we don't cover that. There should be, if we're dealing with medicine as a science, if something is right for a patient presentation, it shouldn't be different based on what insurance card they have. So I sort of thought about this idea body, but hey, we already have the RUC. It has representative of every specialty on it. You could take a body like that and say, okay, you've now got a representative from cardiology and family practice and neurology, and have that body be charged with creating, the coverage policies. And you could have offshoots of those in individual states, because I think it would have to be state specific, to take a look at this, who are the bad actor doctors and who are the bad actor payers. I love that idea.
And Ron, you've hit on a couple of things. And again, we tried that. We tried to get the insurance companies to say, look, here's 10 managed care companies that cover people in South Central Pennsylvania. Mm-hmm. Can you all agree to one set of criteria so that there isn't that if you're carrier A, you get denied, carrier B, you get approved? The answer was no.
No.
So the other place that this was tried was just credentialing, and I'm sure you're familiar with credentialing. Oh, yeah. Can you all just agree to one common set of credentialing criteria?
Right.
No. Right. Everyone wants to have their own proprietary things, and some of the worst criteria I've seen are proprietary criteria.
Oh yeah.
Because a good idea, let's stop bad care, unnecessary care, morphs into let's see what we can get away with.
Right. Well, so, it's both sides of the fence. I mean, the carriers won't get together to do it. And I have an equal example of a specialty client, and a fairly common condition for that specialty. Okay. And it's a big group. And about half the doctors treated this common condition with pharmacologically. Okay. The other half treated it with a more invasive procedure. Okay. Mm-hmm. And the payer was coming to us saying, look, what option A is more expensive than option B. Now, and I try to talk to the group, say, look, you can't both be right. Both sets of doctors. Okay. Either one is clearly clinically better than the other, at which point, why are the other guys doing that? Or they're clinically sixes. And if they're sixes, why are you doing the one that's more expensive? And they couldn't agree. And these are people in the same group, same specialty, who had enormous respect for each other, that couldn't agree. And there's also the famous, I know there was that Tampa study on, north of the Bay, they were doing like radioactive seeds, and south they were doing surgery. You lived based on what you got. And my understanding of the study was clinically, they were roughly the same. It was Coke or Pepsi. So we have the same thing on the delivery side. You want a common set of coverage guidelines across the payers, but you all can't agree for what is the right way to provide care, understanding their idiosyncrasies. There are different patients that go up, but the vast majority should fit into that. So it is a problem on both sides.
Ron, we're not going to generate much controversy because you and I are agreeing way too much.
Well, no, we aren't, and that wasn't the point to have sort of a point counterpoint, but more of there has to be a solution to this, because I think the other thing we agree on is we are going to drive doctors out of medicine. We are creating an enormous amount of unnecessary work on both sides, administrative costs that we don't have. And it's only, a good friend of mine is fond of saying, when elephants fight, only the grass gets hurt, and the patients are getting hurt here. That's the other problem.
So one of my big beliefs is in the idea of transparency. And I think that part of the problem that you're describing can be resolved through transparency and requiring more. Currently, the feds are trying to force transparency on pricing. But I think we also need to try to force transparency on criteria. Mm-hmm. Now, some insurers are, and I'm pleased to say I've been associated with some of these. Some insurers put their criteria on the web. If you're a patient, if you're a doctor, if you're whatever, you can look at their criteria. Yep. As the medical director, I'm very grateful for that, because I can go online and find the criteria from 5 different insurance companies and say, yes, today is the right one because these other 5 insurance companies agree with me. So I'm a believer in transparency. You mentioned, and we've chatted about the idea that the insurance commission for a state can be the sole regulator. But I think with transparency, the buyer of healthcare is not the patient, it's their employer. And it's the feds or the state. Mm-hmm. So the largest insurance companies, Medicare, Medicaid, the Blues, if they could have transparency as to the data that we just talked about, denials, mm-hmm. Bad doctors, mm-hmm. and have that available to them, then their customers, employers, can make a better decision as to what they want. I've been in discussions where an employer said, Joe's in our department and his wife has this. Do you cover that? And the answer is, well, no. You better cover that because I'm not signing a contract with you unless you cover that. Okay, well, we'll have to run the numbers and come back to you. Yeah. You do that.
Well, my favorite one is, and I experienced this with self-funded customers of, one of our executives needs and this was a real one, needs a liver transplant. He's saying you're not going to cover it. And we say, he's an active alcoholic. I mean, it's not that we don't want to cover it. It's that the transplant centers won't do it while you're an active alcoholic. You've got to be.
That's the flip side. There's always 2 sides.
and the employer going, well, I want you to still, we'll figure a senator will do it. I still want you to cover it. And then our answer was, so do you want us to cover it for all of your employees who are active out, or just because he's an executive? Because that creates a second level problem. So yeah, there's none of this that's, I think, completely clean or black and white, unfortunately. So another concern I have is, how do we do this so that it's a process that a patient can get a fairly quick result when they're waiting for care and they think that their denial, how do you appeal rapidly to some external body? I don't know if we did a podcast a while ago with an ENT physician in Arizona, Dr. Hurley, who was dealing with a very difficult cancer diagnosis, and extremely difficult. And he since has passed away. Told was, as an ENT physician, first of all, he got to, one of the world-renowned specialists for what he had. I mean, he said, I have access that other people don't. And they denied a PET scan that his doctor needed. And he said, they needed it partly to mark where my cancer was so that they could tell if the treatments are going to be effective. He said, so I faced this, well, do I wait for the appeal or do I start my chemo, knowing that time is really of the essence? And he decided to start his chemo. So later they overturned the denial, but then his doctor's like, but I don't have the baseline now. It lost that value. And I fully admitted, I don't think that PET scan in all likelihood would have elongated his life at least one day. I mean, that's, I'm not, but part of me goes, he shouldn't have had to even think about that, or there should have been a much more expedited way to get somebody external to look at this. So I guess, how do we also deal with that scenario where the patient goes, hey, I got this denial. I'm freaked out and I'm beside myself and I need this. Somebody needs to happen, because right now the appeal process is not expedited for most carriers.
Yeah. And that falls to the accrediting agencies for carriers, because they create criteria for appeals. Mm-hmm. And they say, URAC, NCQA, et cetera. They say, an expedited appeal must be done in X number of hours or days. And sometimes that's not fast enough. And that the process, which is, I think, one of the major issues in prior auth. Mm-hmm. I mentioned that in practice, we participate with 50 different insurance companies, 10 different managed care companies, and all their processes were different. And they all had their own credentialing and they all had their own payment schedules. If we could unify the process so that it gets done faster, I'm all in support of that. Mm-hmm. There should be a clearinghouse, if you will. Everybody submits things to the clearinghouse. Their clearinghouse processes it so that the GUI, the graphic user interface between the practice and the insurer, looks the same across all insurers.
Right.
Now, I'm sure there are attempts right now to allow access to patients to all their medical records across an entire state or region, et cetera. Mm-hmm. The health information exchange. I was the chair of the board of Pennsylvania's health information exchange when it initiated, and we got that off the ground. It still exists, and it's still working on many of these issues. But that was for health information. Wouldn't it be nice if we could do the similar thing so that the user interface is uniform and the processes are uniform across all of these things? Again, it doesn't strike me that that's not something that can be solved with technology that exists today.
Yeah.
It's just getting everybody to agree, and then who's going to pay for it, and where in the healthcare dollar does that get pulled out of? Mm-hmm. Setting up an HIE was not cheap. Mm-hmm. And having a practice that has, EMR 1 and wants to connect to EMR 5,
right?
They have to set a common set of parameters and exchange data, and that costs money. Mm-hmm. And that's part of the reason that small practices are going out of existence and only large practices remain in existence, because have theoretically more resources to expend on that kind of stuff.
So I'm going to switch gears. I agree, completely agree. I'm going to switch gears, and maybe this will be the closest we get to sort of to disagreement. One of the things that I've sort of offered up, and I know there would have to be controls on this, is that I don't understand why when a medical director signs a denial, why they don't carry some responsibility, just like the physician who makes an order carries responsibility. When you were practicing, if you wrote the wrong prescription and the patient had a bad outcome, that you can be held responsible for that, and not responsible in that, well, every bad outcome is a doctor's fault, but it's that idea of negligent malpractice.
Yeah.
And so I've sort of offered up the idea, say, well, if you're a medical director for a payer and you're signing something, which I would argue in many cases is a denial of care because the patient can't afford it, and you didn't check the medical records, you're rubber stamping what a nurse put in front of you or what a computer said, why isn't that medical director, or at least their employer, have some responsibility when there's a bad outcome? Because the doctor who ordered it certainly did. I'm interested in your thoughts on that.
So absolutely. And I think it's a good thought, and it's a great question. And here's the answer. I'm not a lawyer. And the lawyers that have created these contracts have insulated medical directors from direct clinical responsibility. And as you say, we're not saying you can't have that. We're saying you can't, we're not paying for it. Mm-hmm. And we're insulated by the contract that says we will make our own judgment on what we pay for and what we don't pay for. And there are things that you clearly just aren't going to pay for, so they're going to get denied. And that's, in the insurance lingo, that's an administrative denial, because we don't cover it. There's no medical decision.
Sure.
The solution to that is the same that we talked about earlier, and that is coding. Theoretically, an insurance company, a good one, okay, and I have to preface that with a good insurance company. A good insurance company will review all of the decisions that their nurses make, that their physicians make, and examine their processes. And if they see that physician A, Dr. Geraci, denies 30%, yay, Dr. Geraci, you're denying 30%, congratulations. But 90% of those are overturned on appeal. Mm-hmm. That should be transparent as well. Mm-hmm. And that should be an actionable item. Because then there's two problems. Either your criteria are bad, or Dr. Geraci is bad.
Right.
And both of those can be acted upon and corrected. The old mantra of quality improvement was, there are no bad people, there are just bad processes.
Yeah.
I don't believe that.
Yeah.
I don't believe that.
Yep.
If all you're measuring is outcomes, there are folks who do not do the right thing.
Right.
And I don't want to call them evil. I don't want to label them. I don't want to call them lazy.
No.
But for whatever reason, there are people who consistently make bad mistakes. Mm-hmm. And having worked with physicians who committed errors in the process of correction, I have rarely met a physician who didn't accept correction and realize that they needed to change their modus operandi or get out of the business.
Well, I think you and I both would agree that most doctors, the vast majority of doctors I meet, became doctors by being type A overachievers. You didn't get into medical school by being an idiot. And that's, I think, why they deal with correction well, because they're self-motivated. They're used to being, and they want to be that. But you also bring up another interesting point that I think it gets lost in this discussion about denials, et cetera. And I understand it from a patient perspective, is the difference between a medical necessity denial and then just a coverage denial. Okay. The example I use a lot right now is the new weight loss drugs, Wegovy and Zepbound. A carrier saying, we just don't cover those. They're not saying that they don't work. They're not saying that they can't help you lose weight or improve your cardiac profile. They're saying your employer did not pay, or they're not covered. That, a lot of people sort of lose that nuance, that's not a medical director saying this doesn't work. It's saying just, it's like not having, it's like not having rental car insurance as part of your auto insurance. They're not going to pay for a rental car. And so when I talk about sort of that holding accountability, it's that true medical necessity denial, where an ordering doctor or a treating doctor says, I think this is necessary, and a different doctor says, and I disagree, and we're not going to pay for it. Is, again, it gets back to that they both can't be right to some degree, and maybe the medical director didn't have all the information because it wasn't submitted. There's that stuff that happens as well, but it's that piece that I think is, to me, really problematic, because right now, and we've seen the bad actors who can just rubber stamp it and go, because you're right, the contract protects me. I can't be sued. I can't hold my license responsible. I do think it would be interesting to see the licensing boards, et cetera, say, no, we're gonna call the act of a denial the act of practicing medicine, and therefore it opens up that whole arena. That'd be an interesting thing to see what the payers did with that.
Well, and again, that's a legal discussion, because then they get into that.
Yeah,
I will catch on something that you said, and that is, one of the, and this is going to get a little political here, because I'm going to talk about ACA.
Mm-hmm.
So the idea that everyone should have some kind of health care is a laudable idea.
Mm-hmm.
And so Congress seized upon the idea that we need to create an Affordable Care Act that provides everybody with some level of insurance. I support that 1,000%.
Mm-hmm.
The problem is that the lobbyists jumped onto that and said, what do we call minimum coverage? What is insurance? What is health insurance? What should it cover?
Right.
And the end result was that the package that they put together as a minimum level of care was so expensive that it wasn't affordable anymore. Mm-hmm. And there you have, and that's the thing. We want everything for nothing.
The unfunded mandate, which is one of my absolute drives me nuts language in government. How can you have no, we have to do it. We just aren't going to pay for it.
Right.
So, but you're absolutely right. I mean, that it'd be nice to say everybody should have plenty of food, and everybody should have housing, and everybody should have healthcare. Those are all, like you say, laudable goals, but at some point you got to pay for all that. And you're absolutely right. The lobbyists did get a hold of that. So,
Ron, I'm not sure we generated much controversy here.
Well,
we agreed more than
but I think, from my perspective, the point wasn't to, because Lord knows there's plenty of that out there with people shouting at each other. From my perspective, having you on, the point wasn't to generate controversy. The point was to take an issue that is a hot button right now, understand that there is a lot of common ground, and that rather than have it be a you're wrong, no, you're wrong. All right, well, let's figure out how to make the solutions, and neither the payers nor the physicians in a good solution is going to get everything they want. I work with a lot of doctors who would love to just stop questioning me, let me have what I want. And I talk to payers who'd be like, why are these doctors arguing with us? We decide what this is because that's what we get paid for. Neither side's going to get all of it, or shouldn't. And so that was my, and I think we've done from my perspective what I want to do, which is to start evaluate what are the solutions, because they're out there if we stop yelling at each other.
I agree. And the current environment is so polarized that it, the folks that call each other names are so convinced that their side is right and the other side is completely wrong. And you're absolutely right. If two people negotiate something and both walk away unhappy, that's a good negotiation.
Yep.
If one walks away happy and the other walks away unhappy, that's a bad negotiation.
Yeah.
So I think the solutions are transparency, a methodology for tracking both sides, the amount of work required. It would be great to know, again, not even ignoring denials, but if insurance company A causes 30% more work than insurance company B in doing prior auth and denials, that should be factored into the payment. Too many physicians that I talk to and that ask me for answers, say, well, what can I do? And when I was consulted to help with, challenging physicians that were in hospital systems, I always started the conversation with the CEO or the chief, whoever was in charge. Are you ready to fire that physician? Are you ready to sever them from your medical staff? Are you ready to kick them out? And the discussion that followed that was very much dependent on the answer. So when a physician says, this insurance company is driving me crazy, I ask the same question. Are you ready to disenroll from that insurance? Well, I can't because, I'm in Philadelphia and Capital or IBC has 90% of my patients. You are in no position to negotiate anything, my friend.
Right.
I'll try to help you.
Right.
But there's a limited amount of stuff you can do. Your choices are disenroll and go independent, concierge or, other model, or up and deal with what you have.
Right. Well, I know we're running.
Yeah, if you don't mind,
end of our hour,
Dr. Gus, I got two questions for you as we wrap up. A little bit off the wall for the first one, if you don't mind. Now, you mentioned that you had one of the first practices in Pennsylvania that had an electronic medical record. That is EMRs, and the amount of clicks in EMRs is one of the number one complaints I'm hearing right now from my clients. I know Ron's hearing it. We've heard it from there's memes on the internet that are all about it. And one of the solutions that I'm a little bit interested in is the use of artificial intelligence in EMRs. And if you have any thoughts on that whatsoever, I'd be curious what you think about that, the way technology is progressing with EMRs.
Matt, that's an awesome question, because interestingly, I've had several discussions in the last week or so on that very subject. And in fact, I just posted something today on LinkedIn. So follow me on LinkedIn.
Yeah.
And the answer is that we're not ready for prime time yet. And that was the lead on to my note. The promise of artificial intelligence is absolutely there. But as I said in another comment, I've read too many sci-fi novels to think that AI is going to solve all of our problems without creating more. Having said that, I think here's an issue. When I used my EMR, it made me faster, more efficient, and I was able to close the door to the practice with my notes finished at the end of the business day. Right. And the problem is that, like many other things, government has interfered and the EMR vendors have interfered and created monsters, and they're asking the EMR to do things that it can't do without that some EMRs can do, but they're minor players in the big world.
Mm-hmm.
Right. I often quote a study that I did when I was with an insurer. We looked at quality of care across by size of practice. The very best quality of care was in the smallest practices, 1, 2, 3 docs.
Mm-hmm.
The very worst quality of care was in the very small practices, 1, 2, 3 docs. As the practices get bigger, they tend to converge to a medium quality of care.
Right.
So Matt, I will say there are EMRs out there that will make you more efficient, finish faster. As I said, the EMR I used, and I won't plug them because it's been 20 years and maybe they're different now. Mm-hmm. But the EMR that I used made me more efficient and faster than myself writing notes, dictating notes, or anything else. And it could do dictation, or it could type. And I'm a two-fingered typist. So the answer is not that, a thing that I'm sure you see, prior auth is bad, it's evil, it's terrible. EMRs are bad, they're evil, they're terrible. Not them all, not all of them. There are good ones. Unfortunately, some of the biggest players are the worst. And why are they big, and why are they bought by large health systems? Price, and features, not features efficiency
Right.
and price.
Yeah.
Right.
I worked with a health system. The docs spent months reviewing 2 different EMRs that the hospital wanted to implement. They reviewed them, spent months in demos, hundreds of hours. At the end, they went to the CEO of the hospital and said, "This is the one we want. We want B. We think it's much better." A week later, he announced that he was going with A because they were cheaper.
Mm-hmm.
Yep.
So,
Yep.
what was your second?
Well, and I will just follow up with that. I will say, at least even on the patient side, for a very large one that I think we can all think of what the name is, even on the patient side, I find it a little bit of a pain, which perhaps might be again, you're right. It has to do with price on that one. The final question I've got for you is a little bit more hopeful. I want to know what you are excited about and what you are hopeful for in the future of healthcare administration. What's going on right now that gets you excited about being in healthcare?
Matt, that's a great one, because I will be honest with you and tell you that I am pessimistic.
Okay.
I believe in the pendulum swing of things in both politics and medicine and everything. And I think that things are going to get worse, but I'm an optimist and I'm a Pollyanna. And I think that after they get worse, they're going to get better. But
you know the difference between an optimist and a pessimist, don't you? Experience.
Well, I've got a few gray hairs.
Yeah, we both have earned them. So I will tell you that, when you're answering that, I share that opinion, that I think things are going to get worse before they get better. But I also, and I'll point back to the thing that gives me the hope. I still believe there are a lot of incredibly committed, good people delivering care. And I think we saw what our delivery system can do during COVID. And I mean, I have a client of mine who's an anesthesiologist in the middle of COVID, before the vaccine, and they weren't doing surgeries. So he was doing intubations, because it's all for him to do. And I was talking to him, and he said, "Yeah, I'm doing 10 days on, 10 days off. I do 10 days in the hospital, sleep there, and then I go to a hotel for 10 days because, again, this is pre-vaccine testing wasn't great yet, so I don't know, and I don't want to give it to my family." And I said, wait a minute. You have a newborn, don't you? He said, "Yeah, I haven't held him yet." And I said, "Why are you doing this?" He said, "Because I'm a doctor and these patients need me." And I know there's a ton of those examples. So I share your feeling. I think it's going to get worse before it gets better. And the hope that when it gets better, we can deal with it. There's still an awful lot of incredibly committed people that are going to rise to the occasion when we allow them to do it. That's my take on that, for what it's worth.
I agree with you, Ron. I agree with you 100%. Flip side, there's a lot of doctors who are looking at their watches, and they were raised in a generation of shift work.
Yep.
And they're hospitalists in the hospital for 40 hours a week. And if a patient arrives that's critically ill, they do the minimum necessary till the end of their shift.
Yep.
Because then they can dump it on someone else.
Yep.
So I'm with you 100%. Sadly, there's too many of those kind of people as well.
You're right. You're absolutely right. I want to say again, thank you for doing this. Thank you for your voice online. You're one of the few people that when I see a post, I make sure I read it. I don't always agree with 100% of it, but it always makes me think, and it always comes from a place of I think logic and reason and intelligence, and that's too rare now. So appreciate everything you're doing and what you've done, and thanks for doing this.
Ron, if you could take 2 seconds and put a little plug in for me on LinkedIn, I would appreciate it.
Absolutely. Will do, my friend.
Thank you. I appreciate it. And thank you for the opportunity. I appreciate the time and the discussion, Ron. Matt, thank you very much as well.
Thank you.